We might open up the floor now to questions. And I was told how to get the chat ones up, and I think I've forgotten already. Sorry. Do you want? Is that okay? Yeah. I might start actually. I was interested to see on your last slide about potentially FMT for multi-resistant organisms, and that was going to be one of my questions for you, Patrick. Whether you know much about that at all, and whether that's being done.
I mean, it's certainly a attractive idea, and, you can imagine you had somebody colonized with something horrible going for some, intensive transplant, and you had time to work them up for it. That might be a nice way to decolonize them because other methods of decolonization have never really worked that well, particularly for gram negatives. Um, I don't know much more than the odd case report and small series, but it sounds like it's effective. And if we have a more sort of streamlined process of doing this, maybe that's something we should look more at. But luckily, we don't see too many patients that need it yet.
Yeah, Jason.
Got a question for Hannah. Great presentation. Welcome to Brisbane. Great to have you here. I don't know if this is working, so I feel like I'm quite silly just holding it up. Anyway, my question is relating to how to work out a dose to use, because I know there's been a little bit of work that has been done, but really, I'm not going to even try and make a joke about it. But there's it would be a very challenging thing to do, noting that there's different donors, different levels of microbial diversity, which may exist within some of the donations. How do you guys calculate it? And what is the work that could be done in around that area to be a bit more scientific and personalized?
Yeah, I think you've touched on a really tricky question. So at Biobank, the fecal transplant provider in South Australia, they don't actually work on colony forming units. They work on mass. So they make a general assumption that there are differences, but that in a generally healthy donor, there shouldn't be too many profound differences. So they prepare fecal transplants based on let me just double check. It's 65% saline, 10% glycerol, and 25%, if those numbers work, stool. So it's really just a weight distribution. Interestingly, donors get paid per gram, which yeah. So we have a lot of uni students coming in and donating. I think that will certainly change when we move towards these bioreactor sort of engineered fecal transplants, because in that context, you can't really work on weight. You've got to work on something that's much more specific. A fecal transplant delivered by enema is typically a course is 350 ml enemas. I'm not sure what the volume of your nasogastric was. Yeah, yeah. So that seems to be the magic number. Where that's come from, I'm not totally sure. A course of capsules that is equivalent to that volume is 36 capsules. And we're requesting people in the lead up to take quite a intense 6 capsules a day for 6 days prior to conditioning. And then at ANC 0.8, they start on 6 capsules a day for 2 days, and then they go down to like a long tail of 2 capsules a day. So yeah, who knows? It's a tricky question. But certainly studies have shown that if you don't get a response after one FMT, you give another, and you seem to get better response with more that you give. So is it just a question of more is better? Don't know. Yeah, tricky.
Sorry, quick question for Patrick. Given the outcomes of those Gefidericol trials, what are you recommending kind of first line for like an MBL Enterobacterales infection?
Loaded question.
Yeah, I was worried you might ask me that. It is disappointing because I think that's always been our big hole in DM producers. We've got pretty good drugs for KPC and OXA48 and that sort of thing. I think first thing is to really look at all the other alternatives that are more straightforward. Occasionally, you may be able to get away with drugs that are, still testing susceptible, and you may be okay. But often they are pretty much pan-resistant, as you know. I think if you're going to use Gefidericol, you just have to be very careful with the testing. And having done quite a lot of this and comparing BMD to DISC and whatever. It's tricky, and CSI and UCAS can't agree on the breakpoints. It's completely different, so I think no one quite knows where the truth lies. I'd be very cautious, particularly with some of the NDMs like NDM5, NDM9. They seem to be more resistant to glyphyrocol. I think in an ideal world, if you're going to treat somebody, you'd probably want to get a genomic answer first and look for some of those glyphyrocol mutations. Everybody's trying to work out what to do with this drug because it has its place and it certainly can be effective, but there's more resistance out there than we realized. I think you just have to be very careful, and particularly if you've got organisms that are sort of sitting in that borderline area of technical uncertainty. It'd be great if we had BMD or something to double check. Some of the DIS testing is often not possible. So I think, then it's really scrambling around in your cupboard to what else you could possibly put together. And then people are trying combination therapies, and it's all back of the drawer, seat of your pants, kind of make it up as you go along, which is not where you really want to be.
I think Lana was.
Thank you. I have a question for Bianca and for Patrick.
Oh.
So obviously there's been a huge increase in genomics work in Pathology Queensland, and it's much more available. If you did have this problem patient, especially in NDM, when you're worried about maybe the gene encoding for PBP3, etc., how quickly do you, for clinician calls, how quickly do you think you could get us these results?
What?
No, I shouldn't say that in public. I mean, Bianca's probably better placed because this is her wheelhouse very much. But it's getting much more available. We're doing more runs a week. We've got a new MySeq i100 which has much faster runs. Look, if money was no object, we could get you a 24-hour turnaround time. We'd run one sample, but that's a very expensive way to do it. So it does depend a bit on the volume and demand. In a weird way, if we were doing more sequencing, it would be cheaper and easier and faster. So we're kind of a bit stuck by.
Nice plug.
Yeah, no. I'm actually not joking. I think we should use it more where it's useful. And maybe I'm talking out of turn, but I don't pay the bills. If it's clinically useful to you, and I think more and more we're discovering ways to use the genomics to inform our practice, and particularly in these really difficult patients, why wouldn't you want as much information as possible? We don't always know 100% what all the genomes mean, but often we do. And at least it can tell you, look, I would probably avoid this drug, and this might be a better way to go. And I think Adam's going to present a case later where we kind of use some of the genomics to think about how we treat things, and I think we should do that more and more. But we're feeling our way, and we have the power, so why don't we use it?
Say is yes to we'll do this genomics, we use it for value.
Well, the great thing about the way it's been set up now is that you guys pay for it. The hospital pays for it. So if you want it, we just build you. If it's like ordering a 16S. If you think it's useful, just order it, and we'll bill you. It'll cost you a bit. It actually gets billed back to the ward that the patient's on, so you don't even have to pay for it. But my feeling is, in the grand scheme of the pathology bill the hospital gets, all the billions of pointless ESRs and that we pay for, it's a drop in the ocean. Well, we do that routinely, actually. So that, well, I mean, look, we aim for a 7-day turnaround time. I know that's not great. Real-time genomics, I think we'd have to start looking at things like nanopore. That has its own complexities. Nanopore's not quite mature enough to be clinically reliable. I think it's just there'll be a point where sequencing is cheap and as easy to do as a PCR, and that's when it will be a no-brainer. We'll just do it all the time. We're just not quite in that space. I mean, maybe Bianca wanted to say more about what she plans to do in the next decade.
I know, I think that was a really good answer, but I was going to say that we are very flexible. We don't have set days that we do sequencing on. We've got some kind of mid to low throughput cartridges, so we can do 6 to 8 samples at a time. We definitely want to know about urgent clinical ones because we also have a host of kind of research isolates that we can throw in to like make a run. So I think the bulk of our sequencing is kind of more that surveillance CPEs. So if we do know about clinical ones, I think it's very reasonable to try and get a better turnaround time, and we could likely make that happen. But yes, I mean, we're doing about 3 runs a fortnight, 3 to 4 runs a fortnight. So it's pretty good. Yeah.
You're doing a great job, and thank you. That's really
Oh, thank
useful.
you. We're trying to get a hold of the human genomics NovaSeq and just throw our very small genome bacteria onto that, and hopefully that will reduce some of the cost of sequencing. Okay. If there's no more questions, we might close the session. And I think lunch is 45 minutes. So if you could come back at 1:45, that would be great. Thank you.